Hello everyone, so I wanted to make a video kind of highlighting the changes that we've seen in our FR protocol over the last couple months. So right at the very beginning in March, we were getting changes every single day, emails, sometimes a couple days later they'd even change stuff again. Now that we've kind of entered this maintenance phase of our COVID-19 pandemic, I want to just highlight what's changed and what we have going forward. We're still only responding to echo level calls and red overdose calls. So that's most likely kind of a opioid overdose or a cardiac arrest. There is still the opportunity for us doing rescue calls, so MDIs or rope rescue or BC ambulance assists. So what I want to talk about in terms of that is our PPE. So BC ambulance, as I mentioned earlier in an update on Facebook, has moved to a model that they're using a face shield and an N95 mask on every single call, regardless if it's an influenza or COVID-like call. That's something we're adopting as a department too. So if you're going to assist with BC ambulance or on a rescue type call, and that person says that they don't have any kind of COVID-like illness, which includes shortness of breath, fever, runny nose, or those influenza-like symptoms, then we should be using at minimum a face shield and an N95 mask. Now, if they do have those symptoms, then we want to make sure we're using our full PPE, including our gown, right? And of course, gloves are in always. Now, what we found with these face shields, and I'm going to demonstrate over here, is a couple of them seem to have a weak link and they do break. So we want to make sure that our face shields are in good condition. These are kind of new to us at SSIFR, simply because we used to use goggles, but really the standard is to be using a face shield. This is going to way better protect the N95 mask, and it's going to protect our eyes and our whole face from any kind of droplets or aerosolization that may occur. So that's a big takeaway from the PPE section of this, is that if we're going in to assist BC ambulance or be providing close patient contact, we should be in a face shield and an N95. That being said, we want to make sure we're still only sending in people that are required to do our patient care. So we don't want to have every single person wasting or using PPE to go in to deal with something that really only 1 or 2 firefighters can go into. Okay, so we still have to be fairly thinking about how many people we send into these calls. But when we do, we want to make sure that we're properly protected. We found that COVID, in fact, up to 50% of the cases can be asymptomatic, or they're showing no signs or symptoms that they're sick, which is why BC Ambulance and we've adopted this PPE protection so that we can make sure we're protecting our crews when responding to these emergencies. The next big thing I want to talk about is CPR. So CPR has changed quite a bit from how we used to do it and to how we do it now in COVID. So we're going to talk about a couple different scenarios. So our first scenario we're going to run is fire gets on scene first, BC ambulance isn't there yet. So Josh is going to come on scene. Well, the first thing he's going to do is make sure he's in full PPE for every single cardiac arrest, regardless if it's influenza-like or not. We want to make sure that we're in a gown, we want to make sure we're in a face shield, we want to make sure we're in an N95 mask and wearing our gloves. We want to limit, again, how many first responders are on scene, because when we're doing chest compressions, we're aerosolizing. So COVID-19 is normally spread by droplets. So droplets don't tend to sit in the air very long. Once they're exhaled from the body, they tend to fall fairly shortly. However, when we're doing CPR or when we're using a bag valve mask or oxygen delivery, we have that potential to aerosolize. So it's very important that when we're doing these aerosol generating procedures, such as BVMing or chest compressions, that we are in we're in our full PPE. So that goes for an overdose if we have to BVM or if we're doing CPR. So anyways, I digress and I'm gonna get back. Josh has come on scene. We've identified that this is a cardiac arrest. He's gowned up properly. He does his quick assessment. And then he's going to place a surgical mask over the patient's mouth and nose. Once that's done, he's going to now start CPR. We're going to be doing continuous CPR with no airway management. So we will not start bagging, or providing airway management until BC ambulance and paramedics arrive on scene. So as with everything with normal, we want to get our AED on. We want to be switching every 2 minutes as we normally did, but we're only focusing on compression-only CPR. So continuous compression-only CPR. So Josh is doing that. Paramedics have arrived on scene. So there's two options depending on what level of paramedics is going to arrive. If it's a primary care paramedic, they're going to be using a new device called an iGel, and that will be going in shortly after paramedics arrive. A big thing we want to take away is this inline viral filter, okay? This comes with all of our BVMs, and before we do any airway management, this has to be attached to our BVM or our iGel device. Again, this is a primary care paramedic and will be done by a paramedic when they arrive. They're going to attach the inline filter in. We're going to stop CPR because what we're doing is we're doing compressions. We don't want to generate anything. They're going to take it off. They're going to come in, place the iGel, and again, what I really want to make sure is that this inline filter is in place. This is going to be attached to 15 liters flow as normal, and this is going to be placed on. So the iGel is providing a great seal, and anything that's coming out after we put a bag in is going to be coming out and getting trapped in our filter and not exhaling and aerosolizing into the atmosphere. So once that's in, they'll probably give a breath. They're going to confirm that the iGel is properly placed, and then Josh is going to start CPR again. So as we come to our end of our cycle of CPR,
25, 26, 27, 28, 29, 30.
Again, he's going to stop CPR and we're going to give 2 breaths, whoever's on the airway. Okay? So now that's in, he's going to start again. So that's a big change. BC Ambulance is no longer doing continuous CPR. We're doing 30 and 2, okay? It's kind of funny, we flipped. Fire departments are doing continuous CPR because we're not doing airway management, but BC Ambulance, we're doing 30 and 2. And that's because we don't want to be pushing in as he's pushing down and potentially having anything pop up. So again, we'll show one more time. Josh is just coming to the end.
25, 26, 27, 28, 29, 30.
And he's going to come off, and we're going to put 2 nice breaths in.
Recoil.
Full recoil, and he's back on the chest. Okay, so that's scenario kind of number 1 with a primary care paramedic, fire department responding first. What the other option could happen is 2 EMR crews that don't have the ability to place an iGel could show up. So, if you want to do that, Josh. Again, everything's going to be the same. We're going to have applied our face mask as firefighters when it came on, or our surgical mask. These are located in our kits. All of these. Great. And I'll be doing CPR. So Josh is going to again come in, stop. We're going to remove the surgical mask. An OPA is going to be properly sized and placed in. And just as we've done before, we're going to do a 2-person BVM method. Now, it is exceedingly important that we're not doing our one-handed EC grip that many of us learned, that we're doing 2-handed CPR and we're getting a good seal. So when we're begging in, anything that's coming out here and not properly sealed is aerosolizing into the environment and potentially affecting us as first responders. So with a proper seal, anything that's coming out is exhalating through our inline filter and out, and should filter any infectious diseases. Again, I really want to stress that this is properly placed. So some of our BVMs have been pre-assembled with this in place. Some of them aren't, sometimes it's just located in it. But one of the things you really want to do is stop and check and make sure that this inline filter is in place. I've seen it in the past not be in place. Now it's more pertinent than ever that this is properly in our BVM tree here, okay? So again, he's got a 2-handed seal. I'm going back into CPR. So one of the interesting things right now is Josh and I are showing how we can effectively manage a CPR patient with BVM with 2 responders. Okay, so I'm coming in, as I've got my AD on, I'm coming to my end of my 30, 29, 28, 30. Again, I come off, Josh has his seal, I'm gonna bag, full chest rise, and a bag again. So then you can see Josh, proper seal, this is pressed around. He's got a head tilt to ensure that our airway is open. We've got our OPA placed, okay? He's not pushing down, he's kind of pulling up into the mask, and then I can start. So after 2 minutes, if it's just the two of us, we can swap. Josh can come over here, I can get the seal. But the person who's doing CPR can also be the person who's begging. Generally, you're gonna have another third, a paramedic, or potentially another firefighter, depending on what the officer's saying. Yeah, depending on how many people are here, generally the fourth paramedic's probably going to be going and getting the information and making phone calls to the doc. So that's a EMR, fire responding first with an EMR crew. Essentially, we're just doing the same BVM, OPA that we're used to, but we want to make sure we've got a great seal. Again, I'm going to keep harping on this the whole time I do this video, that our inline filter's in place. And that'll be going until it's either transported or discontinued orders are given. There's one other scenario we might see is that we arrive alongside BC ambulance. Okay, so BC ambulance is there, we're all gowning up, we go in, again, we've confirmed. So if BC ambulance is there, regardless if it's an EMR or if it's a PCP crew, the first cycle of CPR will be done compression only. And make sure covering the nose, covering the mouth. So the idea is if we can shock someone and get that return of spontaneous circulation, and we don't have to submit ourselves to an aerosol generating procedure, that is the best case scenario. So the first round of CPR, the first 2 minutes, will be done compression only. After that, then airway management will take over. Okay? So those are kind of the three scenarios we're gonna see. Again, the big thing, full PPE, make sure our inline filter, and only guys who should be, guys and girls who should be in there, should be there. We shouldn't have 5 or 6 people in there. We should have 2, 3 firefighters at most, along with the paramedics. Okay? Yes, so that being said, all this has to do with adult CPR. Pediatric CPR has not changed very much. The big thing with pediatric CPR is we have to be in our gowns, we have to be in our face shields and our N95, we have to make sure our inline viral filter is in place, but we are still providing airway management without, if BC ambulance is there or not there, we're still begging with pediatric CPR, and we're doing a 15-2 compression as normal. So nothing's changed in terms of infant or pediatric CPR besides making sure that we are in our full PPE. That's because generally pediatric CPR is an oxygenation issue, and we don't want to delay oxygenation when that's probably what's going to help revive them, rather than most likely a cardiac issue with what we see in adults. So the last topic I want to touch on for this video is oxygen therapy and O2 administration. Okay, so essentially what's changed here is kind of the old way of doing it is every single person got oxygen. We made it really simple, 10-liter flow, simple face mask. This is considered an aerosol generating procedure, so we want to make sure that we're in proper PPE when we do it, and then we only really need to do it when it's necessary. Okay, so and how we're going to take that approach is a staged kind of tiered approach to oxygen management. First, we have to identify whether this person should be receiving oxygen, right? So tachycardia or fast heart rate, fast breathing, accessory muscle use, complaints of shortness of breath, cyanosis, which is gluing around the mouth or the fingers, are all indications that that person is hypoxic or going into hypoxia and requires oxygen therapy. Okay, so that's what we're kind of looking for. If they're saying they're short of breath and can't breathe, we want to make sure we give them oxygen. If they're not calling and they're not saying they're short of breath, then we can hold off the oxygen because we don't want to create that aerosol generated atmosphere. So, and when I'm talking about a stage approach, is essentially what we're going to do is we're going to start off with our standard face mask as normal. And again, we're going to confirm that the patient is a candidate for oxygen therapy. We're going to give them the mask, we're going to place it on them. And what we're going to do is we're going to start at 6 liters per minute. So the lowest that's really acceptable with a simple or a standard face mask. So we're going to leave that on. We're going to leave it on for a full minute. After a minute, we're going to reassess. We're going to ask the patient, do you still feel short of breath? Are we still seeing those signs and symptoms of shortness of breath? Yes, then we're gonna move up to 8 liters per minute. And same with them, we're gonna give it a full minute, we're gonna reassess the patient. Do you still feel short of breath? And we're still seeing those signs and symptoms, we're gonna move up to 10 liters per minute. Okay, if they're still feeling short of breath, if they are no longer feeling short of breath, that's fine. We're gonna keep them at 10 or 8 or 6 or wherever. If they're still feeling short of breath, we're gonna get our non-rebreather mask, and we're gonna change them to a non-rebreather mask. So we're gonna bump it to 12 liters per minute. Okay, we're gonna make sure our reservoir is properly inflated, and by doing that, we can just push down on this little diaphragm and should inflate this bag to make sure it's got a proper reservoir. We give it to the patient, and again, we're gonna wait a full minute. If they're still complaining, we're still seeing those signs and symptoms, we're gonna kick it up to 15 liters per minute. We're not gonna go any further than 15 liters per minute, okay? 15 is our max on our non-rebreather, and if they're still complaining of shortness of breath, hopefully we'll have to give them more help at the hospital or the paramedics. If they become ineffective breathing, right? So the breathing rate's less than 10, they start losing consciousness, we have to switch over to that BVM. So if they're ineffective, then that means our oxygen therapy is no longer working, and we want to switch over to a BVM, which is still at our 15 liters per minute. Okay? The only other thing is suctioning is a really big aerosol generating procedure. We have to be fairly aware when we do it. We want to make sure we're in our full PPE if we have to suction. If we can clear the airway by rolling the person, that's kind of our first line. So just be really aware that if you have to use suction, it is one of the bigger aerosol generating procedures. Okay, everyone, that's kind of what I have for you today. Hopefully you enjoyed this video and just kind of got to see some stuff and how it works that we've changed. I'm sure depending on how COVID continues to affect us that this could all change. And thank you very much. Thanks very much for Josh and Warren for helping out here, getting this video out. And again, if you guys have any questions, I'm always available. Shoot me a text, hit me up on Facebook. I'm happy to chat. Thanks very much, guys. Take care.